Hello, everyone, and welcome to the Coronary Corner for SYSTOLE. This is Brilakis, and next with Yader Sandoval, and it's our great pleasure to have as our guest today Dr. Dan Jones from Barts Hospital and Queen's Mary Hospital in London. Great friend, expert in CT management and CT PCI, and he's also the PI for the BYPASS-CTCA trial, one of the big trials about using coronary CT for planning intervention and cath in bypass patients. Dan, welcome.
Morning. It's nice to be here. Thank you for the invite.
Dan, great to see you, Dan. Before we get started, I know we would love to pick your brain about so many things, but I mean, tell us a little bit about more who you are. I mean, you're an interventional cardiologist, and we've had this series on CT guided PCI. How did you even get into this?
Yeah, it's a good question. I mean, so I'm an interventional cardiologist based at Barts Hospital in London and Queen Mary University of London. I split my time 50-50. I'm an academic cardiologist, so I'm either within the university running clinical trials within Barts Cardiovascular CTU or doing interventional procedures at Barts Hospital, and with a specific research interest in CT. I think my CT interest really, when I was training, 10 years ago. Let's go with 10 years. Sounds a good time, doesn't it? 10 years ago. Doesn't make me too old. When I was training, the NICE guidance in the UK really put CT at the forefront in the diagnostic pathway of patients with new onset chest pains, the investigation of angina. And that was probably, I think the UK was probably ahead of the world at that stage for really putting CT at the forefront of the diagnosis. But really CT was just used as a screening tool or a gatekeeper to decide whether you needed further tests. But it was quite clear at that stage that you could get so much more from the CT scan from an interventional perspective to help guide and plan procedures. And that's really where my interest came. To be honest, more from a research perspective than a clinical at that point. I was using CT clinically, but actually what was clear was that we could be using it so much more than we were. And then it was clear that there was a real specific niche. And I was always taught when I was doing my PhD or any form of research that it's important to find an area where there is an unmet need or there is a clinical gap. And that was in the post-bypass patient, and seeing that I think that was a group where CT could really make a big difference, which is, I think, then guided or sort of led to my journey into doing more CT and then looking at that specific patient group.
Dan, was it a specific patient, was it a specific case, or was it just a realization, just working at your position?
What's the term? Fishing trip? I think I had one too many fishing trips in a post-bypass patient in the cath lab searching for grafts that I neither knew were there and often we would get a CT after. It would be like, well, we can't find anything, let's get a CT. And it's like, well, why? That's the wrong way around. As in, why am I doing the CT after 300 mils of contrast not knowing? Isn't it better to do beforehand? And to be honest, there was one specific case where we couldn't find a vein graft to a right coronary artery, and it was a native CTO. So we brought him back, fixed the CTO because there were a few collaterals from the left system. Fixed it was relatively straightforward, wired relatively easily, but only after fixing the CTO was it clear that actually the vein graft wasn't occluded at all. It was widely patent, but we just hadn't found it on the angiogram, and there hadn't been a CT in between. So we'd fixed the CTO. Granted, the graft was on the PLV, and then we fixed the CTO into the PD, but maybe we didn't need to do that if we had all the information up front. And that case always resonates with me. That now I don't use a JR4 diagnostic to get into a vein graft to the right. I would always use a multi-purpose because it's a far better catheter. But it also showed that if you make decisions on incomplete information, you can make the wrong ones.
Interesting.
Yeah, absolutely. And actually, we had similar experience. I was at the VA before, and there was a lot of people with bypass, and we actually had a study that only 10% of people have these graft markers that make it easier for you to find the graft, but 90% do not. And you're right, there are many cases where we couldn't find it, we did something, and then we realized afterwards that, oops, there was a graft there, and we just didn't know about it. So absolutely, I'm in sync with you. This is an area that T can really make a huge difference.
And then something that you brought up before, I mean, again, I'm sure we're going to delve here for some time in the whole discussion surrounding bypass, which is the whole purpose here of this episode today. But you brought up something of interest that I think maybe for our listeners. You say that most interventionalists in the UK are trained in CT, are comfortable, are looking at it. I guess you were alluding that this was part of your training. Maybe can you share a little bit of how is key, like the comfort in looking at these images by the interventional cardiologist in the UK? Is this now almost like for granted everybody does it, or the majority?
Well, I wish it was. I think it's still a minority from an interventional cardiologist, for an interventional cardiologist to be skilled at reading in CT. There's a minority that are probably dual accredited in CT and intervention, but there's a growing proportion of interventional cardiologists that have gained experience, whether that's through structural, so whether or not if you do a bit of TAVI and you do coronary work, then you've gained this additional training and ability to rely on CT before the procedures. But I think most interventional cardiologists in the UK aren't that comfortable looking at CT and probably rely on the report. And a lot of my colleagues will read the report and then use that information to make decisions. Still, there's a gatekeeper. Still, does the patient need an angiogram? And then not use that necessarily in a synergistic way. They may still not look themselves and say, actually, look, that's quite calcified, or that right coronary doesn't come off in the right place. It's a bit anterior. And we still rely quite heavily on our colleagues who were trained to read CT to lead that relevant information on the report. And I think there's still a bit of a disconnect. And I think we still just read the piece of paper. And then it's a surprise when you get pressure dampening engaging the left main, but there's clearly an ostial left main on the CT, or you can't use a JR4 because it's an anterior origin, but because the report didn't say it, it's a surprise to us. And I think there's definitely a need for better training for all interventional cardiologists. And I think that's, maybe it's a generational thing. It's difficult to say that, but I think we use more CT before procedures. People are now more comfortable from a TAVI perspective. There's more of an opportunity to look at the CT scan beforehand. And actually, I think as years go on, I think hopefully, I think all interventional cardiologists should be able to look at a CT scan, at least get the information the key information you need before you put a patient on the table, which you should get from the 3D MIPMA, as if that was sent to PACS. That's a lot of the information you need. But again, we don't get those routinely sent to PACS.
Yeah, absolutely, Dan. And again, what I love is that not only you found the clinical need, but you took it to the next level and did the largest and most critical trial in this area. So how were we able to achieve this? This is an area still of controversy. How were you able to run the BYPASS-CTCA study?
Yeah, well, I think, it was clear. Well, it was clear to me there was an unmet need. It was clear that the patients post bypass surgery, and it's common. There are 1.5 million surgeries performed per year. We all see post bypass patients in the cath lab. 1 in 5 within 3 years of their surgery have had another angiogram, and all these operations are different. The vessels you bypass, the conduits you use, their ostial locations, they're all different. And as you said, only 10% have had maybe sternal markers, or clips, which means that most of the time it's very difficult to find these bypass grafts. And it was clear that we could do it better. We needed to be providing safer, more predictable procedures for patients. And for me, CT was the obvious answer. CT's, excellent looking at bypass grafts. They're larger, they don't move. And therefore you get really good, positive, negative, predictive value, sensitivity, specificity for assessing grafts. So it made perfect sense to me that this was the group that would likely more benefit for a diagnostic procedure. I get all the bit around PCI planning with CT, but with the bypass group, there's so much you can get to improve just a diagnostic angiogram using the CT. So it was clear there was a need. And then we went to a funder in the UK, then the National Institute of Health Research, the NIHR, with a research for patient benefit proposal on the premise that this would benefit patients if procedures were safer, more efficient, i.e. quicker, and that the patients had better satisfaction. And that was the premise behind BYPASS-CTCA, whether or not CT prior to an angiogram and a post-bypass patient was quicker. So it was a primary endpoint of time, of patient satisfaction, and of safety, contrast-induced nephropathy. Could we not only make these, more efficient, but can we make them safer for patients? Because we know that in a post-bypass patient, there's a higher risk of stroke, there's a higher risk of vascular complication, there's a higher risk of contrast nephropathy.
Yeah, absolutely. And the study, as you said, did show shorter procedure times, less contrast. Now, the radiation side, I guess, because the CT has radiation of its own, it's been always a little controversial. What is your take? CT does take, obviously, the extra radiation up front. but then it saves you some of it later on as you have less time in the cath lab and less fluoroscopy time. So what is your take on this? And I mean, many of those patients are old, and maybe the radiation is less important because of less long-term survival perspective. But what is your thought on that?
Yeah, I think I almost see the radiation and contrast as a similar thing in terms of it's much better to have radiation or contrast at two different time points than it is to have it all in one go. So I think it's much better to have radiation from a CT, which is delivered in one area, and then potentially from the cath lab 2 or 3 weeks later to have, even if the radiation is the same, it's better to have it split over 2 time periods than it is over one. And I'd say the same with contrast. There's less risk to the patient. I think it depends a lot on, so in BYPASS-CTCA, we saw a significant reduction in the radiation given to patients in the cath lab. Procedures were, 40%, 50% shorter, 20 minutes quicker. So the radiation was less. But when we added the CT radiation and the cath lab radiation together, there was significantly more radiation in the CT group. But I think you do have to, there's always nuances to any stat. And a lot of the CTs were retrospective. They were used on an older generation scanner, as opposed to now there are more modern generation scanners, maybe with less radiation. We're more likely to do scans prospectively or flash. There's less radiation now with a CT. And I think if we did the trial again, and maybe we could talk about that at the end, I think the radiation dose from the CT scan will be less. At Barts, and in the UK, we follow the ALARA principle, which is as low as reasonably possible. And consequently, I think if we compared the cath lab doses administered at Barts compared to other centres around the world, we use less radiation. And actually, I think if BYPASS-CTCA had been conducted at another centre where the radiation exposure during the lab is higher as a whole, maybe the radiation wouldn't have been higher with the CT, because we'd have seen that much bigger benefit in the lab. So I think we were sort of hindered by the fact that we really don't use much radiation in the cath labs generally in the UK.
No, Dan, and I agree with you. I mean, this is inevitably an investment, right? You're doing an investment at the upfront with the CT. Yes, even if it has a little radiation, the whole point is that you're reducing, all these potential procedural issues, right? And as you point out, with better scanners and whatnot, this will be just way more practical. But a question that I have for you is, both on the trial and now in your practice, how did you guys time the CT in relationship to the procedure? Is there a certain number of days or weeks between the CT and the procedure itself? And maybe even speak about some of the CT acquisition settings. I know that's something that is very, we also deal with all the time, is that many of these patients with bypass have CTOs, for example, and calcific disease. So are you doing like a 2-for-1 I agree with you that you're doing an ALARA for the purposes of reducing radiation, but by the same token, are you maybe even, personalizing some of those settings if you want to also better characterize, calcific disease and CTO in case you also want to plan for the native vessel intervention?
Yeah, no, that's a really good, a really good question. I mean, I think we now have, when we did the trial, we had an older scanner. We've had a recent upgrade, so now we use a photon counting scanner, which, from a radiation perspective and the settings is a whole new level of learning for the imaging team as well as us. I mean, the level of resolution we can now get even in a post bypass patient is exceptional if you can get the sequence right and the contrast dose timed at the right level. So I mean, now seeing, most of these patients have had stents before. As you said, the native vessels are often calcified. Now it's actually much better to give you a better indication not only of the graft patency but an idea of native disease, maybe in ungrafted territories or distal to an anastomotic point. So we do adjust the settings and the KVs to try and maximize the information that we can get in this patient group. I mean, I think one additional benefit in a post-bypass patient, which you don't necessarily get and is considered in someone without grafts, is you get information about your access route. Because in a non-graft patient, we don't image the subclavians. You don't typically see if there's a retroaortic course. You don't know that you're going to be difficulty torquing a catheter because the subclavian's coming in behind the esophagus. And you know whether you give you a far better idea about whether you can get to the to the grafts from the left wrist, or sorry, the left radial or the right radial. And I think that's a definite benefit. I know that wasn't specific about the settings, but often we overlook that you do get this additional benefit from a post bypass scan, which was helpful from the trial. We had a couple of patients with subclavian stenosis on the left hand side, and that was our planned access route to look from the lemur. So instead we chose an alternative access route, which was actually the right radial, because the lemur was patent on CT. So we didn't bother taking the risk of a femoral procedure. We got all the information we needed synergistically using the CT data.
Interesting. And sorry, just to jump in, the timing. Are you doing this, a couple of weeks, 4 weeks, or?
Yeah, no, I'd forgotten the first part of the question when I was speaking. It depends a bit on the clinical indication. So electively, we often try and leave a couple of weeks, because it makes sense to try and leave as much of a gap. And in the trial, the median time between the angiogram and the CT scan in the elective group was about 20, 28, 25 days. So sort of 3 to 4 weeks between the two. In an ACS patient, we tend to do them on the same day. So someone's come in with an NSTEMI, then I did one yesterday. Someone came in, they'd been waiting in one of our peripheral hospitals for 3 days. We brought them across. They had the CT scan in the morning, and we then took them to the cath lab in the afternoon. The CT had shown that there was a patent lemur on the LAD, there was a patent vein graft on the right, but the vein graft to the obtuse marginal had a critical stenosis in the mid-graft. So we shot the native circ just to see whether or not there was a viable native option, just because if there's a low-risk native, that's probably better than the vein graft. There wasn't, so we fixed the vein graft. But we did that then in 60 mils, and the fact that the patient had 90 mils of contrast in the morning intravenously, as opposed to 60 mils arterially, means 150 mils split across the day is much better than 300 mils intra-arterially during the cath. So I think it's the trial, most ACS patients, of which there were 45%, had the CT on the same day. And I think it's perfectly fine to do that, but only if you are sensible and you use the information to personalize the cath procedure. If you do a CT and you take the patient to the lab, read the piece of paper and say there's 3 grafts, don't look at anything else and just engage the 3 grafts, and the patient's probably going to get contrast nephropathy because you've just repeated the test twice. And I think that's the crucial bit of information. You have to use the information synergistically. The graft's patent. Do I need to look at that graft? We should be personalizing the angiographic. What information can I get from looking at that vein graft? Does it fill a CTO? Do I need it? Will it be a retrograde conduit? Or if there's 3 patent grafts, do you need to look at any of them? And that has to be done on a case-by-case basis. Otherwise, you won't benefit from the CT if all you're doing is going to repeat the same information at an angiogram. It's not a panacea to better procedures. You have to use the data correctly.
Yeah, thanks. I completely agree with you. I guess one of the challenges there, I think in the US is much more potentially than in the UK or in Europe, where there's more experience with this, is many people are saying, oh, well, can I trust it? I mean, I'm not so sure. So they'll use it to find the graft, to know where the graft is coming from. But they're still saying, well, I'm not 100% sure about whether the graft is indeed as good as it shows. And I think, as you said, for the grafts, there's much less movement. So what is your take on that? If the graft looks okay on CT, what is especially photon counting as you have now, but even if not photon counting, what is the chance of the graft having a lesion that we're missing on CT?
So in the trial, we had 344 patients in the CT arm. There were no stenoses present within the body of a graft at angiography that were missed in CT. There was 100% for picking up disease in grafts. Where CT or earlier generation CT will struggle is in the native vessel distal to the anastomosis or the anastomosis itself. And often we would then, if there was concern about that level or that area, then we would invasively assess the graft. And again, if you think there's diagnostic information, so if you're planning a CTO and it's a right, and often that's going to come from a lemur, as in lemur retrograde to the right, then shoot the lemur because it's procedure planning information if the lemur's patent. But if it's not for that indication, then CT's excellent at seeing us. I'd make a strong argument that CT, to be honest, I think a good quality CT is better for looking at a vein graft or a lemur than an invasive angiogram, in the majority of cases, because there are too many factors that you can't correct for in an angiogram. You have different catheters, different operator experience, timing the contrast. I think I see so many poor quality diagnostic angiograms in a post-bypass patient. And if you do the CT well, you always see the grafts well. Always.
No, you're right. And I think we do see these angiograms where the catheter is not engaged in the lima and you have a whiff of contrast going down. You're not sure what is going on. So I could not agree more with you.
Dan, and I think many of the insights that you're sharing are quite interesting. I mean, I can tell you that I think we have been doing for sure CT in the outpatient setting. The ACS case that you shared, I'm not sure that we are there yet on a broader aspect in the acute setting. But let me ask you something now. Go into the practicalities and the messages for the practicing interventional cardiologists. Tell us a little bit about your day-to-day flow, like in these cases that you're doing. Are you looking with the images with the cardiac imager or radiologist? Are you looking at the report? Are you looking at this yourself? I know that for native vessel, as you very well know, both of us were part of the P4 trial, and you guys enrolled just at an impressive pace in this trial, and others. I know that you were looking at the images and say, oh, this is the axial, this is the MPR and MIP and whatnot. And I think interventional cardiologists are increasingly getting comfortable and looking at the natives. But now for bypass, should we do the same thing? If my next patient in the lab has a CT, I guess at this point you brought it up a couple of times. Should I rely on the report or should I pause for a few minutes and interact with the data? Tell us about your workflow in these cases.
Yeah, I think it's so. I think there's two bits. There's working with your imaging colleague so that the report tells you the information that you need, because there are reports that you may get for any CT scan, and then there's a report for a patient post bypass. Whereas I think there's additional bits of information that we've worked with our colleagues, and then all of my imaging colleagues are excellent at reporting bypass, and they report them now in standardized ways that give the information that we would want. And some of that's come from the trial. So when we were doing the trial, just knowing that there's a 2 veins, a lima, and something about severe the first report for the first patient in the trial said, lima to LAD patent, vein graft to right patent, vein graft to OM patent, severe 3-vessel disease. That was the first report we were given for the first patient in bypass. And we then realized that we needed to work with our colleagues to say, well, look, actually, where does that vein graft to the right come off? Where's its relationship to the sternal wires? Can you give me an MPR in a 30 LAO for that vein graft to the right, so I can see where it's coming off directly in relation to the fourth sternal wire? Where, on the axial slices, what o'clock is it coming from? Is it coming anteriorly? Is it, because the veins get put on in often bizarre locations. It's not the same as a native right where it's 10, 11, 12 o'clock. Sometimes you can see a vein graft to the right at 9 o'clock. So we ask now for the anterior, inferior on the axial slices. We ask for relationship for sternal wires. We ask for some images and MPRs so that we know where the grafts arise, and we do ask for more detailed information about the native coronaries, even if that's again the ostial locations, and then whether there is a way of assessing. To be honest, often if they're blocked or not, because most of the time, in fact, I think all of the time, I always look at the natives in a post-bypass patient. The only time might be is if there's a CTO and I'm really not considering the patient substrate for it. I might not, but that's a minority. So I think it's good to have a rough idea of what you're dealing with the natives. But I think the important thing is to work with your colleagues and ask for that information on the report, and that is relationship of the graft to the sternal wires and the location in terms of anterior or inferior, posterior in the axial slices. Because then you and the images so that you can have them in front of you, because then you know what you're looking for. So if you have to get into the graft, which everyone might still want to, but if you know where it is and you can clearly see where it is, then that helps. And that, I guess my second point is, I think it's always good to look at the images yourself. I admit when we started the trial, I had less experience at seeing a post-bypass CT, whereas now I've looked at all of the cases in the study and continue to do so. So I'm far more comfortable just using PACS to look at, just scrolling up and down in the axial slices, looking at the vein grafts, looking at the lima, and getting an idea as to whether they're patent, whether they're blocked, where they're coming off in relation to the sternal wires. And I think it's a combination of the two. But if the interventional cardiologist isn't comfortable, and they will get comfortable the more they do, then work with the imaging department beforehand so that they can give you the information, because they can do it. Every report can provide the information. We should have a standardized way a post-bypass CT's reported, because it does make it much easier in the cath lab.
Yeah, thanks, Danny. I think you bring up an excellent point, because for us too, and I think many centers, there is often this difficulty, like trying to get the images can be challenging sometimes. So if you don't necessarily have to have a dedicated software like Vitria or etc. Quite often you may be able to just go into the packs, look at the axial images without having necessarily the full MIPS and MPRs and everything, and still get a lot of information that can be useful for your procedure. So that's a nice shortcut for people who don't necessarily have access to dedicated software. But tell us a little bit. I know that you're taking this a step further in terms of a new study with and bypass graft. So tell us a little bit about your current efforts.
Yeah, thank you. Well, so the BYPASS-CTCA study, as you kindly highlighted earlier, we saw that in 688 patients in a single center trial that the CT up front meant that the procedure times were shorter, less contrast nephropathy, and patients were happier. But we also saw a reduced rate of clinical events out to 3 years. So there was a 27% reduction in spontaneous MI events and also unscheduled revascularization. And we think that's been driven by more complete diagnostic information. People pick the right things to treat because you have all of the information to guide what you do. And sometimes you have an incomplete diagnostic series, then you make the wrong decision, as I think we alluded to earlier. But the trial was single center and was powered off a surrogate endpoint, and the CT was only used to facilitate angiography. So in patients where there were widely patent bypass grafts and we didn't think there was a target, we still mandated angiography because that was the trial design. It was, could CT plus angiography be better than angiography? So we are now in the process, and we've secured funding and are setting up a multi-center follow-on trial, very imaginatively titled BYPASS-CTCA 2. I should say like the sequel or something, but it's just BYPASS-CTCA 2, where it's a multi-center trial powered off MACE, 1,000 patients. And in this study, it's CT versus angiography. So if the CT suggests you need an angiogram, then you would have it. If the CT suggests that everything's fine and you don't need to have the angiogram, then you would deviate from angiography based upon the CT. So it's really almost now a head-to-head comparison. Because I think the first trial showed if you're going to do an angiogram, you should have a CT. Now, the question is, can it replace, and can we improve hard clinical events? So what was the first trial? It wasn't powered, but is that signal reflected in a multi-center trial across a wider group of operators? Because obviously there's going to be more variation with more centers. So can we reflect that in a 20-center trial?
Yeah, perfect. I mean, that's an amazing study and I guess much needed. And I think that would help also propel it further out. I think many people still are skeptical about not imaging the graft with CT, although as you said, it's probably better in many circumstances. So having this prospective trial, I think would really put these concerns at rest.
Dan, one other question as we, try to wrap up here, but very interested in your opinion is, I think, it's just kudos, for all this work from data and trials. This is what moves forward the field. Now, you were talking about interacting with the data and using the packs to look at this, which I agree. This should be something that we should encourage because it's easy, practical, available. But I think something in the native coronary space that has accelerated implementation is, all this AI softwares and things that show you 3D models easily with black or physiology. Do you see in the future that we will have similar information for bypass that will reduce the number of clicks and it will just make, the information way more accessible from understanding of anatomy, plaque, and I don't know, maybe even physiology. Can you speak to that? Is anybody working on this? Are you working on this?
Yeah, I think any benefit you would get from, automated software and things that improve the familiarity of interventional cardiologists with the data would be transferable to a post-bypass patient. I mean, I think as you've said, most interventional cardiologists now in a non-bypass patient would still use PACS and rely on their colleagues for the NPRs and the actual interpretation. I think the first step I think has to be that there is a wider availability of everything you just said from an AI in a non-bypass patient, and then yes, I think everything that's been done for a non-bypass could be done in a post-bypass patient. I think the physiology is always a bit of most of the physiological things are validated in a non-bypass group, but there are conversations and work going on with some companies where hopefully we'd be able to get physiology in a post-bypass group. And actually, if anything, it might be even more helpful, because it can be really hard in a post-bypass. It's a complex anatomy you have to take into account not only the native circulation and often different branches of it, but also where the graft is anastomosed and whether it's patent, and whether the graft on the OM is filling the AV circ, which has got a proximal stenosis, which may or may not be subtended, and actually where is the ischemia coming from. And we use quite a lot of hybrid CT rubidium PET before an angiogram to give us sort of an idea as to where the ischemia might be. But it would be great if that information was available without the second rubidium test, and we could get physiology just from the CT. And I think from some of the AI software, again, there are a few companies that we've been talking to and working with to see if we could automate graft analysis, because I think I've talked a lot about working with my imaging colleagues, but I know at the start there was a big reluctance to provide the extra information, because it was extra work for them, for benefit for me, arguably benefit for the patient. And now the trial's completed, everyone can see that, and that's why it's routinely done. But I think as we as interventional cardiologists don't really like doing post-bypass angiograms. I like them more with the CT, but I don't think anyone really likes hunting for 4 veins and a lemur and some native vessels. I think my imaging colleagues don't really like reporting post-bypass CT scans, because there's an awful lot for them to take into account. So if there's an AI way of auto-segmenting graphs and giving you the answer, I think everybody's a winner, and that is the future direction of travel.
Thank you, Dan. And Dan, that's been phenomenal, and really appreciate you taking the time. And it looks like the field is moving rapidly, and there'll be more automated solutions down the line. Maybe a final comment. What would you recommend for people who are at the earlier stages? And I think most interventionalists are not as familiar with using it for anything, especially bypass grafts. So what is your recommendation? How should people take this on? Should they start from the natives, they move to the bypass, or even do the opposite, start with the bypass that are often harder and then go to natives? What is your advice?
Yeah, I think it's don't be afraid of CT, as in a large number of patients before they hit the cath lab have had a CT scan. Get used to opening the CT scan on PACS, scroll through the axial images, start to get comfortable with what the coronary arteries look like. Look to see what calcium looks like. What does a normal vessel look like? What's diseased? Calcium's easy to see. How much? If I'm honest, it's much easier to see a bypass graft and make an assessment than it is of a native vessel. It's a big circular structure that runs down the middle of the mediastinum. You can't miss it. And actually, I think it's much easier to see them and get comfortable with looking at the origin of a vein off the aorta and how it courses down. And then you then start to get an appreciation for the native coronaries when you get to the anastomosis. So I think actually that's a bit easier. And I think aside from getting familiar yourself with just playing around with the software, it's engage with your colleagues. We all have colleagues who are keen to teach. Everyone that I work with in CT is very happy to talk through a scan with me, to let me go to CT and look through some images and to talk through the basics. If you know the basics, you can then work through PACS yourself, and you'll just get more comfortable the more you look at. So I think my advice would simply be, if anyone's on your cath lab table and they've had a CT within the last few months or the last 6 months, have a look at it, because you'll then directly be able to correlate what's in front of you on the CT with the angiogram, and you'll soon realize that it's important to do, and there's so much information you'll be able to get from it, and it really doesn't take long.
Wonderful. Are there any final thoughts and comments for Dan?
Well, Dan, I think this was just remarkable. So many lessons for all of us. I mean, I think congratulations on just identifying an unmet need, as you said early on at the beginning of the episode. and trying to figure out a way to solve that problem to help patients, and now really pushing forward the field with trials, which I mean, because of course we want data and good data to really inform the practice of our patients. So really congrats that. Manos, maybe what should be the closing 2 or 3 key messages that you would like to wrap up, and thank you, Dan.
Well, actually, I would leave it to Dan. I think what he gave us is some very practical recommendations, which is, as you said, just look at the CT. That's how it starts. In the beginning, it won't make much sense, but then the more you do, the more sense it will make. I think number 2, don't be afraid of bypasses. I think all of us in the cath lab have a little hesitancy, like, oh my God, it's going to be another hour trying to fish for this. It's the opposite on the CT. It's actually easier to look at bypass grafts than it is to look at the native coronaries. And number 3, I think I want to congratulate Dan. I think the BYPASS-CTCA was an outstanding trial that really helped us open our eyes to what can be done. Now we have Proctor as well that gives us more insight about what to intervene and what not. And I think combining all this information together can help us make the best decision in the cath lab. So Dan, thank you so much for being with us today, and congratulations for everything you've done on this field.
Pleasure. Thank you very much for the invite and your time.